Good morning. It's Saturday morning in New Jersey, and this is Dr. Nick Tulo with my Saturday morning clinical live stream. I'm really happy if you join me live, and if you have any comments or questions, please feel free to type it in. If you guys haven't watched this before, I am a cardiac electrophysiologist, and I practice in New Jersey, but I am also the creator of ECG Academy, and my YouTube channel ECG Doc has been up for quite a while and has gotten millions of views. So I really appreciate you guys being out there, and I wanted to bring my expertise to you because sometimes arrhythmias are difficult. In particular, today's talk is about pacemakers. Yeah, pacemakers are complicated, aren't they? A lot of times people will bring you a strip and it's a paced rhythm, and you kind of really don't know for sure if things are working right or not. So I thought this would be a really interesting case to go over, just to kind of give you a little bit more insight into how pacemakers work and how to diagnose pacemaker problems. So let's get to this case. So we do spend a lot of time in the burn ICU, and those patients are very, very ill, as you can imagine. And sometimes they have cardiac problems, which is why they ask us to see patients. So this particular patient had a cardiac problem, and they had a pacemaker. They had had a pacemaker for some time because of sick sinus syndrome. So they asked us to kind of evaluate things, and when we first arrived on the unit, I'm going to show you the electrocardiogram that we found. The patient, it's basically a baseline electrocardiogram. So let's just get this up here. Okay. So let me grab my pen and write a little bit here. Okay, so got to get everything ready. So then, see if I can write here. Yep. A little bit thinner. You know, these live streams are a little complicated, but you know, in my ECG Academy Chalk Talks, they're very edited and very concise. But this is kind of a cool way of presenting things live, and you can ask questions. I see we have a couple of people watching already, so thank you so much. It's really cool that you guys are out there watching. So when we look at this rhythm strip, the first thing that I notice is that there are these really sharp, spiky pacemaker artifacts. And, you know, you can usually recognize those, but you have to decide if this is an atrial pacing spike or a ventricular pacing spike. And it's usually pretty easy to tell because an atrial pacing spike will be followed by a P wave, which is right here, and then a ventricular pacing spike would be followed by a QRS complex, obviously. So if you're not familiar with how to read pacemaker electrocardiograms, I do have quite a lot of content on ECG Academy, and there's a link in the description down below, and you can take a look at that. But basically, what I see is an atrial pacing spike, and it's followed by a P wave, and then there's a QRS complex, but there's no spike in front of the QRS. And so it would appear that these QRS complexes are conducted, because after all, when you pace in the atrium, you get a P wave. If the AV node is intact, that QRS complex will be inscribed by the conduction system. Now this QRS does look a little funny. It looks a little wide. There's kind of an RS, R prime appearance. So the patient very well may have a bundle branch block, but there's no ventricular pacing spike. So this looks like atrial pacing. Atrial pacing at a rate somewhere around 70 beats per minute. Just guessing 300, 150, 175. Yeah, about 70. Okay? Now, this is an interesting beat right here. Just for your information, the QRS looks similar to the underlying beats, but yet a little bit different. And even though there's an atrial pacing spike, the PR interval is extremely short. So it seems that this P wave that arose from the pacing spike couldn't have conducted that quickly. So this beat came from somewhere else. It certainly didn't arise from the atrial spike. So this is probably a PVC, a premature ventricular contraction. And even though it looks similar to the normal beat, it's obviously a little bit different, and it comes prematurely, and the PR is way too short for this to have conducted. So I'd simply call it a PVC. But then you have some more atrial pacing here, and then in the second strip, more atrial pacing, another PVC. This time, look at that. There's no spike. There's no atrial pacing spike in front of it. So this obviously came from the ventricle. There's no P wave in front of it either, because if you look at this T wave and compare it to the previous T wave, you don't see a PAC there. So it's a PVC. Hi, everybody. I'm really glad to see there are a few people watching. So everything's fine, except for one thing. Well, at first, let's talk about pacing and pacemakers and how pacemakers work. So can you figure out if this is a dual chamber or a single chamber pacemaker? Well, it's almost certainly a dual chamber pacemaker, because single chamber atrial pacemakers are very, very rare. I mean, in the US, basically nobody puts them in, a single chamber atrial pacemaker. In Europe, perhaps in someone with pure sick sinus syndrome, it might be an option. But here we're always worried that, well, what if AV block occurs, and you want to have that ventricular lead there as a backup. So let's talk a little bit about pacemakers, dual chamber pacemakers, and how to recognize the behavior. So basically, dual chamber pacemakers, or DDD pacemakers. What does DDD stand for? Okay, this is some basic stuff. The first letter is the chamber or chambers that are paced. Think of the word pacemaker, so the first letter is paced. So you have A for atrium, V for ventricle, D for dual, so that's capable of pacing both chambers. The second letter are the chambers that it can sense. So if it's able to sense atrial events or ventricular events or both, then you have A, D, or B, or V. A, V, or D, sorry. And then the third letter is kind of like, how does the pacemaker behave when it senses an impulse? So some pacemakers are inhibited, and you get an I in the third category. For example, VVI, a VVI pacemaker, means that it paces in the ventricle, it senses in the ventricle, and if it sees a sense beat, it's inhibited, which is basically your demand ventricular pacemaker. So, but dual chamber pacemakers are able to do something else, and that's to act as in a way that's called triggered. So it means that pacing is triggered from a sensed event. And one of the most common triggers is that if an atrial event occurs, then that triggers a ventricular event. And so that's so there was a pacemaker that was marketed years ago, and it was called a VAT pacemaker. So it sensed atrial events, but it paced in the ventricle in a way that was triggered. So basically, it was a single lead pacemaker that was pacing in the ventricle, and it had an atrial sensor up here. So it was able to sense the P wave and then pace in the ventricle. So the ventricular pacing was triggered off of the atrial event. And this was a perfect kind of a pacemaker to use in somebody with complete AV block, because you don't really need to pace the atrium in that case as long as they have normal sinus node function. So that's where the T comes from, was triggered. There's some historical things, but I don't want to get too bogged down. But D, when you have D in the third sense, it means it can do both. It can do both inhibited as well as triggered mode. So when you have a DDD pacemaker, there are 4 different characteristics, 4 different types of behavior that you can notice. So one is atrial pacing, and that's when the sinus node is not working properly, but the AV node is working okay. So the sinus node is no good, and the AV node is good. And so you have no atrial beats, right? Sinus node is slow, you have no P waves. So the pacemaker paces in the atrium. Paces in the atrium, and it's followed by a P wave, but that AV node is healthy and normal, and so it conducts normally to the ventricles, and you have basically atrial pacing at the lower rate limit and normal conduction. And that's kind of what we see here, even though there's a bundle branch block. But there are a couple of other behaviors, just so that you know. What if you have sick sinus syndrome and you have AV block? So there's no conduction down the AV node, or at least the AV node conduction is poor. Then you'll have an atrial pacing spike, but since there's no conduction, you'll also have a ventricular pacing spike, and we just simply refer to this as AV pacing. Okay, so that's more common than the atrial pacing. Now, what if the sinus node is working fine? That's where the pacemaker can sense the P waves and trigger ventricular pacing. So let's say you have somebody with normal sinus node function and they have complete heart block. What will happen is the P waves will be sensed by the pacemaker, and it will pace synchronously with the P waves because there's no intrinsic AV conduction. And so you'll have something called atrial synchronous ventricular pacing, or VAT pacing as we used to refer to it. Finally, if the sinus node is good and the AV node is good, the pacemaker may be inhibited in both chambers. Both channels are sensing events, and so you just simply can see a normal sinus rhythm with normal AV conduction and no pacing activity at all. So dual chamber pacemakers are capable of all four of these types of behaviors. Okay, so let's get back to this strip. And so here we have basically atrial pacing with some PVCs. Now, they called me to tell me that every now and then the pacemaker, every now and then the heart rate would go up. And they couldn't figure out why. The patient was tachycardic, up to like 120 beats a minute. So, you know, these monitors, they kind of store 24 hours and they'll give you a heart rate trend. So I looked at the heart rate trend just to get a sense of what it looks like. And this was the heart rate trend that I saw. So you have on the left-hand side the heart rates up to 50 and 100 beats per minute. So most of the time he's pacing at about 70 beats per minute. But every now and then you get a little bump in the heart rate. And then this is what they were concerned about. Look how crazy. All of a sudden the patient's heart rate goes up to like 120 beats per minute. And then it kind of gradually goes down again. Excuse me. Sorry about that. I was so rudely interrupted. So you have this rapid heart rate, and that sort of gradually comes back down again. And then you have, again here, a rapid heart rate up to about 120 beats a minute, and then it sort of gradually comes down again. And so they were like, well, why is it tachycardic? Why is the heart rate going up like that? So you look at this and you say, could be an arrhythmia, could be atrial tachycardia, could be atrial fibrillation, could be sinus tachycardia, I suppose, but the patient is basically lying in bed, he's intubated, he's sedated, he's kind of not really walking around, so it really couldn't be sinus tachycardia. So when I clicked on one of these tachycardic events, what I found was interesting, and here it is. This is the tachycardic event. So what do you see? Well, I see a fast heartbeat. So the heart rate now is about 120 beats per minute. But what you have to notice is that there seem to be spikes. But the spikes are coming after the QRS complex. Isn't that crazy? The spikes are coming after the QRS. So here's the QRS. The spikes are landing on the T wave. Like, oh my goodness, like something's wrong? Is it like pacemaker malfunction? Is it undersensing? It's a spike on a T. I mean, weren't you taught in medical school that, you know, if a pacemaker spikes on the T wave, it's bad? But what's interesting is that here's another one of those PVCs, and you notice that this spike here sort of lands on the interval after the T wave. And it's followed by what? By a P wave. So these are actually atrial pacing spikes because there's a P wave following them. And the P wave is followed by a normal QRS. And then you have another spike here, which is then seems to be followed by a QRS. So these are atrial pacing spikes. Now, wait a minute. The pacemaker is supposed to be pacing at the lower rate limit. You program it for 70, and that's what it's supposed to pace at. So why is it suddenly pacing the patient at 70 beats per minute? Well, Ricardo thinks it's upper rate behavior, and that's a very good thought. But with upper rate behavior, what we're generally referring to is tracking, the tracking rate. Okay, so let's go back to the pacemaker. So when you are tracking, it means that you are synchronously pacing the P waves. You're tracking the P waves. So an atrial synchronous ventricular pacemaker, if a P wave occurs, it's followed by a paced beat. Great. But what if the atrial rate goes up to 180? Does the pacemaker try to keep up with that? The answer is no, because there's always a programmed upper rate limit. And the upper rate limit, just like the lower rate limit, the lower rate limit is, okay, when the pacemaker is just pacing in the atrium, whether it's atrial pacing or whether it's AV pacing, the lower rate limit is basically the pacing rate, where would it be 60 or 70 or whatever you program it. The upper rate limit, which is also a program parameter, tells the pacemaker, well, how fast can you track? How fast are you willing to go? What's the point, the heart rate, the atrial rate that the pacemaker says, I ain't tracking this? Because chances are it's probably some kind of arrhythmia, and so I won't go above this. And the upper rate limit is usually, when the pacemakers come out of the box, it's usually like maybe either 110 or more likely 120 beats per minute. So what upper rate behavior refers to is what does the pacemaker do if the atrial rate is above the upper rate limit? What does the pacemaker do when the atrial rate is 130? And that's actually a complicated subject. I do cover that in the advanced course on ECG Academy. And I don't want to get too bogged down into how upper rate limit behavior, but basically upper rate behavior refers to the upper tracking rate. What happens when the atrial rate is faster than the programmed upper rate limit. But here, that's not what we're talking about. Here what we're talking about is it's pacing in the atrium at 120 beats per minute. Why would the pacemaker do that? You've probably heard of the expression, runaway pacemaker. Run away, woohoo. The runaway pacemaker was a term that was sort of coined in I think the 50s and 60s because they had single chamber pacemakers, and the way the circuitry behaved is if the battery got really, really low, if the battery voltage got really, really low, the timing circuitry would malfunction. And you would see very rapid pacing, and that was a problem. But we don't really see that anymore. Runaway pacemaker is really not something that we see. But what it's doing, though, is it's pacing in the atrium at a rate of 120. So it's pushing the patient to higher rates. What would make a pacemaker do that? Anybody? Since the lower rate limit is programmed for 60, right? What would make the lower rate limit go up? I'm giving you lots of clues here. Okay. So when we talk about DDD pacemakers, there's a fourth letter. And that fourth letter is the letter R. Okay? When you say that somebody has a DDD-R pacemaker, what does that mean? The R stands for rate adaptive or rate responsive. And this is a feature that pacemakers have had probably since the 1980s. In fact, when I was a medical student, I graduated in 1982, so they had it then. The first pacemaker that was capable of rate adaptive pacing was called the Activitrax. It was made by Medtronic. I remember when it came out. What does rate responsive pacing mean? It means that the lower rate limit, which is the lower rate of the pacemaker, will change depending upon the patient's activity. Now, how does the patient know? How does the pacemaker know what the patient is doing? They used to have a piezoelectric chip, which is basically a vibration sensor. And so when the patient was physically active, walking or climbing stairs or moving around, the pacer would actually pick up those vibrations, and the lower rate limit would increase. And the reason is this: if somebody has normal sinus node function and they go walking, their sinus node will increase. In fact, if you look at an exercise, if you have somebody who's sort of like a normal heart rate, you have like 70 beats per minute, right? And they're going at 70. And then right here, you start exercising. You put somebody on a treadmill. What happens, their sinus node will basically ramp up to whatever. And if you exercise them hard enough, what's the maximal predicted heart rate? Anybody know that? If you do stress tests, you know. The maximal predicted heart rate is 220 minus your age. So your sinus node, a normal sinus node, will ramp up that high. And like right here, if your exercise ends, it basically will gradually slow back down to baseline, right? Everybody does that. Everybody's used a treadmill. You know that's what normal sinus node function is supposed to be. If this is, say, 150 or so. Okay, so in people with sick sinus syndrome, what happens is they start out really slow, and they may have something called chronotropic incompetence. You know what that is? It means that the sinus node is not capable of increasing appropriately when someone exercises. So someone with sick sinus syndrome, if they exercise, they may only hit rates of 70 or 80 or 90 or something, and then they very quickly come back down to normal. And their resting heart rate may be quite slow, 40, whatever. So what a pacemaker would do, if you just had a regular DDD pacemaker, is basically that patient would wind up sitting at a heart rate of 70 all the time. And if they exercised, maybe they would go to 75 or 80, but they would be stuck in first gear. They can't do anything. So rate adaptive pacing was invented to restore a more normal heart rate response to exercise. So exercise drives the lower rate limit up. It causes the lower rate limit to ramp up to an upper sensor rate. Okay, that's the second upper rate limit that most normal pacemakers, most modern pacemakers have. You can set an upper tracking rate and you can set an upper sensor rate. Now, the sensors have evolved, and you don't always have vibration sensors. Now they have a chip, and it's called an accelerometer. So when you move, this little chip, sort of like inside the can, senses that motion. And the accelerometer feeds into a circuit that can determine what the patient's activity is. So when somebody is running, they're vigorous, they're doing things, it'll drive it up to a higher rate than if you're just kind of leisurely walking around the block, looking at, don't the leaves look lovely this time of year? Okay, so the upper rate limit, the sensor will vary depending upon the patient's activity. So that's what rate adaptive pacing, rate responsive pacing is, and that's what the R is, that's the fourth letter. But then, how do we explain this? The way the pacer is behaving is that it's pacing at the upper rate limit, at the upper sensor limit, which is 120 beats per minute in this case. Why would it do that? So the patient's critically ill, they're lying in bed, they're intubated. So I turned to the surgical resident and I said, do you guys doing PT on the chest or thumping something? And he's like, oh yeah, the bed vibrates. The bed vibrates? I said, yeah, it loosens up secretions and no, that's the answer. Because when you look at the trend, you see that there's this big burst of activity, and it goes on for maybe about 5 or 10 minutes, and then the rate gradually comes back down to normal again. And that's what was happening. The physical movement of the bed was activating the pacemaker's rate adaptive pacing circuit and driving the pacemaker to the upper sensor limit, the upper rate limit of the sensor. So what it was doing is this, and then when you look at as the trend was coming back down, here's the next one. You can see that it's still atrial pacing here at a rate of about 90 beats per minute, but it's gradually coming back down. And so that's what was happening, is the pacemaker was driving the heart rate because it felt the vibration of the bed. If you can actually tell, if the patient's hooked up to a heart monitor, if you just tap the pacemaker rapidly for about 30 seconds, you'll see the pacing rate go up. And you can tell, but only if the R is turned on. That's a programmable feature. It's programmable, so you can turn it on or you can turn it off. And you can also change the sensitivity. So some elderly patients who don't move around much, you can make them more sensitive so that when they do walk to the bathroom, their heart rate will go up more. But a young person who's out on the tennis court, right, with sick sinus syndrome, they're going to be much more vigorously working, and they're going to be generating a lot more vibration, a lot more motion. Accelerometer is going to go crazy. So you can dial down the sensitivity in those patients and get it to restore a more normal heart rate. In fact, younger patients, we generally will program the upper sensor rate at like 140 so that they can get up to higher heart rates and improve their cardiac output and feel more normal. So I really thought that this was so cool. And I don't think I've ever actually seen this, or if I have, it was a long time. And I was like, wow, how cool. So they thought he was having arrhythmias, but you can call this pacemaker-mediated tachycardia because it's mediated by the pacemaker, but it's working the way it's supposed to. It's normal pacemaker function for the circumstances. So, of course, you can do one of two things. You can stop doing the PT, or you can reprogram the rate adaptive pacing off, or you can just kind of like ignore it, right? Because after all, a pace rate of 120 beats per minute is not necessarily harmful. The patient's blood pressure was fine. He has no symptoms because he's intubated and sedated. But I just wanted to present this because I just thought it was really cool. Anyway, with this beat, I mean, you do have atrial pacing, and then you have a PVC. And then look, right here, I guess that PVC must have conducted retrogradely because I think you have a retrograde P here. And so that suppressed the sinus node long enough so that now you have AV pacing. Isn't that cool? So just so you recognize AV pacing, and the AV delay here looks like it's programmed for about 150 milliseconds or so. So you can see pacemakers change the way they behave from one beat to the next depending upon the patient's needs. So really cool stuff, and I hope you enjoyed this discussion. Tell all your friends, your colleagues, that Saturday morning, most Saturday mornings at least, I will be doing these live streams. You can subscribe to my YouTube channel, ECG Doc. There's a link in the description so you can click on it and you're subscribed. And if you want to learn more about pacemakers, how they work, how to troubleshoot them and everything, please check out ecgacademy.com. There's also a link to that educational website. It's a subscription website, but it's great. It's all video tutorials just like this, a little bit more concise, but I try to bring my expertise in electrophysiology to people out there in the trenches who are reading ECGs on a day-to-day basis. So I really appreciate your coming and watching, and if you're watching this after the fact, thanks so much. Please like this video and subscribe to my channel so that I can bring more cool stuff to you. It's really a thrill that I have so many fans out there, and if you have any other comments, please don't hesitate to send me an email if you like. You could do that through the ECG Academy website or send me a message. And until next week, this is Dr. Nick Tulo. Thanks for watching.